Drugs, 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 drugs. Today we are going to talk about the top 5 drugs that you must know as an ICU nurse. Stay tuned. What's going on, nurses and nursettes? This is Cordero. Welcome back to A Couple Nurses. Before we get into today's content, be sure to like and comment Nurses Rocking the Bottom if you find any value with this content today. And also check out our podcast that Monica and I are dropping. It's called Code Blue and Bullshit. You can find it on Apple, Spotify. All the links to that will be down below. So today, we're gonna talk about the 5 drugs or drips that you should know as an ICU nurse. I literally used all 5 of these yesterday when I was at work. We're gonna talk about 3 vasopressors, and we're gonna talk about 2 sedative medications that you should definitely know if you're gonna be working in the med-surg ICU. All right, so let's run through these medications real quick. We're gonna go first to go over vasopressors, which are medications that keep the heart rate and the blood pressure up. So the very first drug that we have is 𝘼 also known as norepinephrine. We use this one very often in the ICU. This is an alpha-adrenergic, which means that it's going to work on the blood vessels. So it's going to constrict the blood vessels, peripherally to help keep the blood pressure up. So you're pretty much concentrating the blood to your heart. We can titrate up to 30 micrograms per minute at our hospital. At other facilities, it may be different. Also with 𝘼, it's very important to assess the peripheral. So you want to, check cap refill that y'all should be doing often anyways. But since the blood is really concentrating towards the more central to your body, you definitely need to be assessing peripheries, see if the hands or feet are cool and blue. The next drug that you need to know is epinephrine, also known as adrenaline. This works more on the beta-1, so it works more on the cardiac. If the patient is tachycardic and you have 𝘼 and epinephrine running, you may want to titrate down on the epinephrine before you titrate down on the 𝘼, because the epinephrine acts on the heart rate more than the 𝘼 does. It's also good to know that epinephrine can also work peripherally as well, so it also has alpha-adrenergic effects, so it can also peripherally vasoconstrict. We generally, at our hospital, or depending on the patient's condition, we generally want to titrate off epinephrine first and then titrate off 𝘼. But again, it just depends what the patient is presenting with, and that's really just what kind of directs your care. And then the last pressor that you should know as an ICU nurse is vasopressin. So vasopressin, they use this for diabetes insipidus. It pretty much is a strict vasopressor, so it doesn't work on the beta-1 in the heart. So pretty much what that is doing is just keeping your blood pressure up, and at our facility we keep it at 0.04 units per minute, and we don't titrate that one at all. That's just a continuous infusion. And pretty much how this works is that it keeps you from peeing as much, so it decreases urine output, which increases the fluid that you have in your vessels, which increases your cardiac output and increases your blood. Okay, 3 down, we're gonna knock out 2 sedations. So the 2 sedatives that we use most often is Propofol. Propofol is a general anesthetic. It is weight-based, so it's very important that you know your patient's weight and you don't guess, because you could be giving them too much or not enough based on the weight that you put into the IV channel. It's also good to know that Propofol is short-acting. This is good to know that if you titrate up too much or don't titrate up enough, that it's very quick. So even when you're changing tubing for Propofol, that you should be changing every 12 hours, by the way, that if you're changing tubing and it's taking you 5 minutes, that patient's not going to be sedated anymore on the vent. We use this for mechanically ventilated patients only. If the patient is not on a mechanical ventilation, there is no reason that Propofol should be infusing into this patient. And the last thing that you should know about Propofol is that it is not analgesic. It only keeps them sedated. It doesn't have any properties that are helping with pain regulation. So a lot of the patients usually have PRN pain medications or on a continuous fentanyl drip. And the last medication that we're going to go over is Precedex. I was doing some reading that said Precedex shouldn't be used for more than 24 hours. But Precedex is a sedative that we use at our facility most often when we're trying to wean the patient off of propofol and we're weaning them from the vent. It also helps with anxiety. Precedex is also weight-based, so make sure that you have the patient's weight as accurate as possible. The patients can be extubated on Precedex, which is different from propofol, but again, you don't want Precedex running for a long amount of time. You want to take that off as soon as possible. So that's it, the quick and dirty. I'm still pretty new to the ICU, so these are just medications that I see most often. If you guys are like an older nurse or an older ICU nurse or found anything that I said that was incorrect or can add to something that I said, then definitely leave that down in the comment box. We're open to learning, right, all the time. But definitely if you're in the ICU, these are things that you're gonna see most often. Vasopressors, which are lever-fed, epinephrine, vasopressin, and you're also gonna see sedatives such as propofol and Precedex. Hope you guys found value in this. Comment nurses rock at the bottom. And until next time, guys, peace.